Oh, it says
connected
live.
it. No, it says that we are live only on the streaming key.
Oh,
I'm
okay.
just waiting for Dr. Zaim. Yeah, just to save time, I connected it to the streaming key. So whenever we would want to go live, I would need to just press a single click from my side. So
Oh, okay.
I'm sorry. I'm sorry because I've just seen Dr. Zaim's message in the WhatsApp group. His laptop is undergoing some updates, and he is saying
Okay.
that he needs 5 more minutes or so. So it's a
Okay,
call of
no
the group.
problem.
That do we
Just
need
let me
to wait
know.
for him? Yeah, sure. Just do we need to wait for him, or other option is that we can start and he can jump in whenever his laptop is ready. So up to you people, whatever you decide.
I think we should just wait like a couple more minutes and then
Okay.
start.
Okay.
Yeah.
Okay. Let me just inform him that we are waiting for him and he can take his time. All right, team. Because we had scheduled the session in advance, so we have automatically started going live just a few seconds ago. So we can now formally start the session. Thank you so much, everyone, for your presence and coming to the session today and sparing time. Over to you, Mr. German, for the opening. Thank you so much, everyone, and stay geared for a wonderful discussion ahead.
Good afternoon, everyone, and greetings from the U.S. Embassy in Islamabad. Welcome to the Pakistan-U.S. Alumni Network Public Interest Group session, Health and Risk Communications. We are so grateful for your time and interest in this very special event today. We hope to learn through our discussion and engagement with our special speakers today. Just wanted to introduce myself in today's program for you. My name is Juan German, and I am a public diplomacy officer here at the U.S. Embassy in Islamabad. Today's program includes a panel discussion from renowned subject experts. It's an incredible opportunity to hear firsthand their perspectives on this very important topic and that is still affecting us today. We're thankful to the three Fulbright alumni, Dr. Zaeem Ul Haq, Dr. Fareeha Irfan, and Dr. Ali Hussain, who are working in the local government health sector and higher education institutions. And thank you to them for being panelists today in today's session. It is my privilege to share with you that this year marks the 75th anniversary of the United States and Pakistan bilateral relationship. To strengthen this bilateral partnership, the U.S. is dedicated to supporting and assisting Pakistan in its fight against COVID-19. In fact, to date, the United States has donated over 57 million COVID-19 vaccine doses to Pakistan. The long-standing health partnership and investment in Pakistan have provided the technical expertise and critical infrastructure needed to bolster preparedness and rapidly respond to COVID-19 to control the pandemic and save lives. The United States remains committed to doing our part in partnership with Pakistan. Also, I would like to share that last week we participated in the groundbreaking of the first permanent headquarters for the U.S. Educational Foundation in Pakistan, USEFP, marking a new milestone in the 75 years of the U.S.-Pakistan relationship. In 1950, the United States and Pakistan officially formed a bilateral commission, now known as USEFP, to exchange master's and PhD students. Today, USEFP manages a wide range of educational and professional exchange programs here in Pakistan, including the largest Fulbright program in the world between Pakistan and the United States. And many thousands of alumni of those programs are leaders throughout the country. Also, you are part of the Pakistan-U.S. Alumni Network that has over 37,000 alumni members, and it continues to be the largest alumni network of U.S. government-funded exchange programs in the entire Department of State. So without further ado, on behalf of the U.S. Mission in Pakistan and PUAN, we are thrilled to welcome today's session moderator, Dr. Rakhshanda, legislative fellow program alumna, and to all of our guests who are joining us live on the PUAN Facebook page. It is my honor to be here today with you to celebrate and to discuss and to have this discussion. And over to you, Dr. Rakhshanda, to begin this program. So thank you very much.
Thank you, Mr. Juan German and all colleagues from PUAN. And I'm super excited, thrilled, and nervous as well, because I'm going to have a wonderful session with my three experts who are brilliant, and they are my personal favorites as well. And we have Dr. Zaeem Ul Haq, who will be joining us shortly. We have Dr. Fareeha Irfan. We have Dr. Syed Ali Hussain. All these three experts are Fulbright scholars, and they received their early education from Pakistan, and they have been trained in US. They are into research, they are into advocacy. So as we say, that they know the nuts and bolts of this subject, health and risk communication. And so this is very broad, but they have their own areas of expertise and interest. And each panelist here has a very interesting trajectory. So while waiting for Dr. Zaeem Ul Haq, who would be joining us shortly, I take the liberty of starting this panel discussion with Dr. Fareeha Irfan. And by the way, let me tell you a bit about the structure. It is like loosely structured because we have an audience, not only PUAN alumni, but people, professionals who are interested in these areas outside PUAN, and we are doing it live on Facebook. So it's a very, very special session on this very important subject. And I will be asking a general question from all the panelists, and then there will be some specific questions according to their own areas of interest and expertise. And then there will be a concluding question. And last but not least, we will be interacting with the audience. So keep your questions ready. And because our panelists are ready to respond to all questions. So Dr. Fareeha, as I can see, she will be giving a presentation. But before starting your presentation, Dr. Fareeha, I would like to ask you that what is your primary motivation? I mean, why is it relevant to talk about health and risk communication? And I will be asking the same from Dr. Syed Ali Hussain before Dr. Fareeha starts her presentation. And did I tell you all that Dr. Fareeha also happens to be a surgeon? So tell us more about yourself as well, and your motivation, and why is it relevant to talk about health and risk communication? Over to you.
Hello, everyone. Assalamu alaikum. I am Fareeha. I'm a medical doctor. Did my training in surgery, and then I switched fields to public health. And while I was in the US doing my master's, we did a lot of work on risk mitigation, especially in the context of humanitarian logistics, disasters, climate change, and just preparing people for what lies outside of our very protected existence. And that all of that actually prepared me in a way for what was waiting back home in Pakistan. While I was training in surgery, I came across a lot of young women who had breast cancer. A lot of them had advanced breast cancer when they presented to us. So that was my motivation for switching fields, because if you can't prevent it or diagnose it early, you lose a life. And so that was how I got interested into this preventive strategies and well, public health in general, but especially telling people what they can do to protect themselves, because the challenges are going to keep coming at us. They're not going to stop. My nephew was asking me, he's 10 years old, a very smart kid. He's like, what if we make a shield to protect ourselves? How do we protect ourselves from diseases? Like, we can't protect ourselves like that. What we can do is, be more prepared, which is why I'm here. So this is my motivation. This is my driving force. This is the impetus behind everything that I do these days. And over to Dr. Rakhshanda now. So others
Okay,
can
thank
be.
you, thank you. So I can see Dr. Zaeem is here. So Dr. Zaeem, we wanted to start with you in reverse chronological orders because we know as medical students that anybody's name starting from Z is always, at the last, but your computer, I think we heard that did not cooperate. So the topic is about human behavior, but we may be talking about machines as well. And we have technology experts here. So with your permission, I'll go to Dr. Ali first to know about his motivation because he has very interesting trajectory. I mean, with IT, with creativity from NCA to academia. And so what is your real motivation? Why you are interested in this subject? And why is it relevant to talk about health and risk communication? Dr. Syed Ali Hussain Sahab, please.
Thank you very much, Dr. Rakhshanda. So I've been mostly interested in media and communication from the beginning. That's what took me to NCA, where I learned about multimedia arts. But then I was interested in using the media and communication for social sector intervention, not commercial sector interventions. So I've been working in NGOs in Pakistan. When there was a big earthquake in Mansehra and Bagh region, then there was a USAID funded project on mother and child health, and I was working there as behavior change communication manager. And then there were floods in the southern Pakistan, so I was working in the regions of South Punjab and Sindh. And this is where I basically observed, this is before Fulbright. So this is where I observed that what we are doing is sort of a missed effort. It's a hit and trial kind of an effort. There is not really having a lot of impact. Even if we are having an impact, it's very short term. It's not sustainable. And I could see from the audiences who we care so much about, the beneficiaries, that they know that it's not working. And I felt a lot of guilt for that. And I also realized during my experience working with international NGOs that there is a solution to it. Evidence-based practice, evidence-based campaigns to influence audiences' attitudes, beliefs, social norms, emotions, and habits have been done in other parts of the world, like in Africa, Mexico, and many other countries. So I was not aware of that, and I learned about Fulbright. I applied for Fulbright. It was a wonderful experience going through the interviews and stuff. And this is how I went into the health communication at Michigan State University, where I did my master's and PhD. And so this is all about, and then so my main field is social influence and persuasion. I design communication campaigns for the audiences using technology to influence attitudes and beliefs from unhealthy to healthy behaviors. It's not limited to health. It can be for environment also. It can be for gender also. It can be for many other purposes. And this has been a very exciting journey so far. Thank you.
I'll come back to you and ask a question because that is something very difficult for a person with average IQ like myself, about machines and algorithms. So I will ask about you. But Dr. Zaeem, just like Dr. Ali, you are a double Fulbrighter, but starting from Rawalpindi Medical College and seeing closely the NGO sector and the social development industry in Pakistan and knowing how government works, you got trained as a Fulbright scholar in US, and then you returned and then you work with government ministries and you saw the devolution from Ministry of Health to Health Services Regulation. You had been advising and leading and managing. You did a lot of things, and now you are, into that very famous Gavi alliance, and in the middle of the pandemic, because I'm pretty sure it's not over as yet. So tell me about your motivation. Why is it relevant to talk about health and risk communication? You are an expert. And what inspired you to invest your energy, your time into this particular area? Because you started as a medical doctor, and they are infectious diseases as well, and there are other areas. So why health communication and risk communication?
Yeah, thank you very much, Dr. Rakhshanda, for all the kind words. Assalamu alaikum, and thank you to all the participants who have joined us. Talking about health and health behaviors, including treatment behaviors, is part of a doctor's life, and that's how I entered into talking about these, which is in a nice way called health communication. So over 15, 20 years, I realized that this is an important, very important area, and this COVID has just highlighted how really critical it is. And I think we'll be talking more about it during the course of our webinar today. But as far as I was concerned, after my medical degree, I also entered into pediatrics and worked as a pediatrician for about 10, 15 years. And that was a time when I realized how important it is to be, communicating in a way that the parents of the child understand, and the child also feels comfortable while attending a physician's clinic. Most importantly, it's my success if they understand things. And once I was able to, achieve that, then I also started thinking about why they come to my clinic, because they become ill, and they become repeatedly ill because something is happening at their household, in their environment, by their families, which can perhaps prevent them from becoming so sick so frequently. So it's about water, it's about hand washing, it's about nutrition, etc. And that actually led me to the wider area of public health. And within that also, I was also always interested more in how to help them and how to talk to the people. And then once I moved into it, and luckily I was awarded the Fulbright and I entered into a PhD training. So that opened to me another, new universe of knowledge. Wonderful experience of going to the US universities and learning from them, and being able to work with, luckily I have been able to work with a number of universities from the US. So of course, that's a long discussion that we can do at some other point, but as a pediatrician, I realized that how important it is to communicate. And this COVID has actually taken that realization to a very heightened level. And I think over to you. We'll be talking more about COVID now.
Yes, Dr. Zaeem, thank you for, sharing your journey, at least a part of it, and your motivation and what inspired you. But before going to Dr. Fareeha, requesting her to talk about vaccine hesitancy and, infodemic, I would like to, ask you, Dr. Zaeem, that since, you have seen the North and the South, both, that pandemic treated, or how they treated pandemic. So what do you think that as of now, what lessons have been learned, or what should have been learned or not learned? And if you look at the health systems, if you look at different, politics in the context of a pandemic. So I want you to quickly, share your insights.
Yeah, thank you again. I think throughout my career, I have realized this, and I've said it so many times, and I've heard it from so many others as well, that health communication is a combination of art and science. And I found it very interesting, and this makes the work very interesting. And when you say that this is a combination of art and science that helps to save people's lives, so it adds value to the combination as well. But the real realization of actually how important and how saving lives really means came during the COVID, especially the first year, when it was, changing at a very rapid moment across the globe. So there were a number of, learnings that I'm sure not only myself, but my colleagues and colleagues across the world went through those learnings. And I shared those learnings. If you allow me to share my screen.
I would request Shahnila to enable the screen, please.
It is enabled from my side. You just need to click on the green button, share, saying the screen share. Perfect.
Yeah.
So I'm trying to make it full screen. I hope it works. Yeah.
Yeah.
All right. So I was saying that actually I'm reflecting on the events that, especially during the first 3-4 months of the pandemic, that were unfolding, and events like 700 people in Iran who died because they consumed methanol. Because of a misinformation over there that methanol cures COVID, the virus, and so much of other misinformation, which everyone must be recalling, but also so much of the information that was around, and that perhaps has helped so many people to take the desired action. Was it the adoption of non-pharmaceutical or non-pharmacological interventions, distancing, hand washing, etc. So this pandemic over the 2 years have evolved, and the challenge has been enormous, and we have had to adapt our response, including the communication response. So these are a few of the learnings that I thought I would like to share. And let me start with the global picture. These are the 3 graphs as of yesterday, and they are about the total number of cases in the world, the total number of deaths, and the vaccines. And I mean, it's important to have the context in which we are discussing. It started about 2 years ago, and we have about 430 million cases so far in the world, about double the population of Pakistan. We have had 6 million deaths in the world, which is about how much? Like the combined population of Islamabad and Rawalpindi. Imagine a whole twin city has been wiped out. Yeah, so this has not happened in a day. There were things that have changed over time, so it has evolved. The virus initially was not known. It was being called novel coronavirus. Then it changed and subsequently caused successive waves. It's changed to beta version, then to ultimately to Omicron. And there has been burgeoning of the virus throughout this time in some part of the world. Even today, it is happening. And These virus variants had variable transmission and mortality rate. And of course, over these 2 years, we have had vaccine, and also we have come to know the variable effectiveness of those vaccines. So important from the communication perspective is that a communicator's job is to relay the information so that people can consume it. But this was a situation in which there was no finality of the information. The information was evolving, the virus was evolving, and the communication had to, address this whole situation, which was enormous in many ways. Enormous in the ways of numbers, but also enormous because it was happening throughout the world. So the information was also being transferred and transmitted throughout the world. Within a second now, we all know that because of the social media and mobile phone technology, people can share information. So this required a transition from the traditional health communication approaches. And I'll be talking a little bit about those in the next slides. But one important thing was that to address this enormity, it was the government, the politicians, the media personnel, and other influencers who were, at the forefront of communicating about this issue. And for a user, the information was coming from all sources, all directions, and it included all types of right and wrong information. And then the emergency response also had to adapt, which also involved, certain element of information. Like we all remember the bending the curve phase during the first few months. Everybody was talking about in the entire world, and everybody thought that bending the curve, imposing strict lockdowns is the only solution. There are people who still debate about it. But over time, people realized that it's not the strictness, and it's not the strict lockdowns that are going to help. So an adaptive emergency response over the time evolved. It did not happen in a day. It evolved over time. So which means information was also evolving over time. And the information transmission process also had to take that into account. So a couple of other things, and I think infodemic management is what Dr. Fareeha will be talking in her talk. But moving to the next, what guidance did we have when the COVID started? This is a graphic that presents, the guidance that is available with from professionals and bodies who have been dealing with health communication, and the word has evolved over time, over decades. Initially, it used to be called health education, then health communication, then social and behavior change communication. Sorry for the acronyms. Then certain organizations like UNICEF call it communication for development. But overall, the guidance is the same, and that is that communication is a process. It starts with a set of analysis activities, and then coming from that analysis, we develop a strategy. That strategy has to be around some theory of the individual behavior change. And once that strategy is finalized, the program goes to the material development and then implements those interventions and evaluates, and whatever is learned is reinvested. So it's a cycle. That's the kind of very useful guidance that was available from health communication side. But the COVID made us realize that this guidance imagined a static problem, something like contraceptive behavior, something like nutritional behavior, something like hand washing. So it's not changing every day, but the virus and the virus situation was changing every day. So the other thing was this guidance did not factor in a lot of information that is converging onto one user, one person. And so what to do with that? So it was not, very clear. Of course, and that even if it said that communication is a cycle, but there was a certain sort of linearity in the development and and availability of a lot of time. So these were the things, that the new challenges that COVID threw into this health communication. And we also had some good guidance about risk communication and community engagement before COVID-19. And this framework, which comes from Peter Sandman, was adopted by CDC as well as in some of the work of WHO as well. It's a very useful guidance, and I was a fan of it before the COVID and during the COVID, because it allows us to quickly compartmentalize the way people are thinking, and then think about appropriate messaging. So it says that use data and identify 4 strategic quadrants to come to the conclusion that that is, guided by a formula, which says that risk is equal to hazard and outrage. Normally, the scientists factor in only the hazard, the probability of, something happening. And they do not, or usually do not, before this guidance, they would not consider the feeling which is around a person who is to consider that probability. So this formula guides us that if there is a lot of noise, a lot of concern in the environment about some problem, even if the problem is minor, the perceived risk will be higher. So, and it allows us to, as I said, compartmentalize people who may be in a low hazard situation, still thinking about that it's a high hazard because the noise around them is high, or at certain other situations, the hazard might be higher, and they might be thinking, they may not be very, highly outraged. So an example of these situations from the COVID would be in the March of 2020, when the virus was just about hitting Pakistan, and there was a lot of noise, whereas the experts were counting the number of cases and the probable, transmission and the probable number of cases, and they were thinking that no, the virus is not very hazardous. It causes only minor infection, and the recovery rate is, high. Therefore, it's a low hazard. But the media and the environment and the social media, they were, making hue and cry, and there was a lot of concern about that. On the other hand, when in the month of May and June that year, 2020, just around Eid days and afterwards, when the restrictions were released and people were suddenly out and they were not practicing some of the advised practices. So, and the cases were rising and the deaths were high. So it was a high hazard, but it was being perceived that perhaps people are not, bothered anymore about it. And they're not. So there is low outrage. So this is a useful guidance that was there. But again, there were certain areas that this guidance did not address, and those areas came into in front of us during COVID. And one of those was that the situation was changing so fast that measuring the outrage and measurement of the even hazard was a problem on an ongoing basis. And also, our realization was that this framework suits to the news media and to the current affair programming and the quick messaging, because you have to titrate and quickly, phrase your new messages according to the new situation, which is evolving. The mainstream or the traditional approach of health communication, which is, involving various kind of stakeholders and doing entertainment education and doing social marketing, which takes a lot of time, that had little space in this challenge or challenging environment. And lastly, this framework was directed mainly to talk to individuals, to the communities. It did not take into account other influencing layers, which were extremely important, and that's what we saw during the COVID. So these were the previous guidance available about health communication and risk communication. Now we turn to, our face to Pakistan. Like elsewhere, Pakistan too underwent 5 or maybe 5-ish waves. We have had how much? I think 1.5 million cases so far. Luckily, the transmission rate and the number of cases have been low. The number of deaths is about 30,000, again low. And but again, the pandemic has evolved like elsewhere. As I said, it has been less severe, but that severity has been questioned, and that questioning is part of the communication environment, because that ties to the trust area. No doubt that because of the lack of resources, Pakistan has not been able to do adequate tests, and hence the number of cases that are being reported are always questioned. However, one proxy indicator is the number of deaths, and that has been low. So that gives some suggestion about why the number of cases are comparatively low. Like elsewhere, the enormity of the situation required the government to come to the forefront, including the communication, and it did. One of the innovative steps, I say, policy level, was the creation of NCOC. And there was this feeling before NCOC, and the NCOC also ensured this, that the main messaging going out to the people should be in one voice. So there was less, dissent, although it was there. And in a pandemic, no one can avoid that. But there was an attempt to achieve one voice. The difference that Pakistan adopted from other countries in terms of the overall response, the most prominent was an adaptive lockdown approach. If we recall, even the first speech of the Prime Minister, in that he said that he was not very favorable to the strict lockdowns, and it has to, take into account all those people. That's an interesting question. At that moment, it did not appear that this decision was based on a scientific evidence. It was more of an emotional and a feeling for the common man or the poor man, but it worked. And over time, the discussion that I've had with experts from elsewhere, and the gradual guidance that experts from elsewhere have, come up with, is that it has to be titrated. And in the words of Peter Sandman, one has to dance with the virus. So if it is spreading, it is burgeoning, you have to tighten your approach. If it goes a little, on the dormant side, you can also relax the restrictions. In terms of communication effectiveness, we achieved during the first year up to 70% of the compliance, which again is questioned as well. But whatever surveys were done independently, those reported masking and hand washing behavior up to 70%. And we have delivered 210 million doses in our country, in a poor country. So that's a huge success, with 50% fully vaccinated. And the recent studies have actually shown that there is a certain tendency of people who is shown or that tendency is shown through certain, behaviors, including vaccine, and I'll be talking a little more about that towards the end. Moving forward, so that was the situation of Pakistan. It was evolving. We had an adaptive response. Mainly, the communication interventions were through the news media and current affairs. And this is an image of a paper in which we published our overall strategy. And our current and former health minister both were very kind to be co-authors, and they gave very important input. And I have provided the link. I would just quickly like to show the framework that we adopted during that intervention development, the execution of strategy. And there were a number of things. What we tried to do was use data, be adaptive, carry out multiple types of interventions, and use the news media and current affairs programming and main media as the main, main medium, coupled with social media, and of course, whenever there was possibility of doing the on-ground activities. One of the things that we, I believe, that was an innovation from Pakistan was the use of mobile phone, and you all have been, through that experience of calling someone and first having to listen to that ringtone. We started in March 2020, and it is still happening. This slide shows an ongoing work on the analysis of the data around that intervention. And it had multiple advantages, and I wish we had more time to talk more about it. But we ensured, or we thought, that mobile phone ringtone is perhaps the only way that nobody who wants to throw a misinformation can use this, this method. People can talk, people can transmit misinformation during their talk show. People can transmit misinformation through social media. People can do it through WhatsApp. But an official or what should I say, a mainstream phone system cannot send you a message which is misinformation. So it had its inherent value that this information which is coming is, the listener would think that it's absolutely correct. And this is for me. And it had a very, dedicated listenership. Then it had the widest reach. If we have, if the data is correct, that we have about 150, 160 million mobile users, then everyone calls or makes a call, and on every call they can listen to this. It also ensures uniformity of the information, and it enabled control of being able to craft the message, control of the messaging within the health department. Otherwise, you give information to anyone, to a health worker, to a media anchor, to even a health minister, and when they will be, disseminating that information, that will be paraphrased, and that will, have a chance of going away from the standardization. So those were the things, and within this, the small text that you're seeing is actually an example, or the examples of the 3 behavior change theories that we used for developing those messages. And the data is around the effectiveness of individual theories. As I said, this is a work in progress, but the initial findings are that the threat-based health belief model messaging, as well as the extended parallel process model-based messaging, which both are basically saying that there is a threat and there is an action. If you do it, you will be saved. Versus another kind of message, which was social norm promotion, which said that other people are doing this, and we should also do this. And our finding is that the social norm-based message worked a little better. But as I said, we are still analyzing this data. And moving forward, since we are talking about the lessons, and I believe this whole exercise or the whole discussion of today will be around those lessons. So if I have to synthesize the evolving situation, enormous situation requiring adaptation is itself a learning. And within that, the biggest communication learning was one, that the science has its own communication challenges. You know, the robust science comes from, for example, randomized trials. And in a pandemic, you don't have space to carry out randomized trials. And when there are no randomized trials, the science tends to use the language of probability, likelihood, relationship, not the causality. And what people want to hear is causality. So that has been a challenge during this evolving situation for the science communicators. Another challenge has been, and this has been throughout the world, that the science fraternity, although is part of the team of the decision making, but they are not at the topmost hierarchy. So whenever the topmost hierarchy wants to use their presence or their statements, they are invited. Otherwise, their input is not incorporated. And there are so many examples. The most recent is the UK announcement, in which the Prime Minister was very, blunt. Everything has gone, but their Chief of Health, he was very cautious, and he, was kind of saying that we should be going in a stepwise manner. Then the enormity. So the enormity of the situation required using, mass media approaches, current affairs, news media, quickness. And that also meant that the non-health personnel, the health ministers, the anchor persons, the panel discussants who may not be health people, but they have, the eyes and ears of the people. They were talking about health and they were communicating health. They may not have capacity to do that, especially when it comes to debunking the misinformation. It's a skill. And we have seen from across the world examples in which in an attempt to debunk the information, actually it was repeated again and again. So that was a challenge. And it was a challenge for the health and risk communication professionals as well to partner with those non-health actors and help them and build their capacity because they are at the forefront. So this is again another kind of learning that we have had. We have seen less adaptive and innovative approaches. Our mobile phone ringtone is one. And I think that's one kind of research question as well, that how many real innovations have been tried. I'm sure there would have been across the world, but that's a good research question. And finally, a bit of evidence that is available. I am showing that in my bullets, but my major point is the number one, that the volume of COVID-19 information on the news and current affairs and main media has been enormous. I tried to do a quick research before this discussion. I could not find any information on how many stories New York Times have done so far, how many stories BBC has done, so on and so forth. And then what has been its content? Who has been the proponent of that information? What was the kind of intent behind that information? How much was the engagement achieved by that content? And what kind of effect it had? So no doubt, mass media, the news media has been the major, source of information, and we need to now we need to know what was done and how much effect that news media has achieved. What we know from smaller studies is, one, that even in media, there are certain, dispositions. So those who, across the world, those media who were right-winged, leaning towards right-wing, conservative, they were pushing content that was of low scientific quality. While those on the left side, left-leaning media, they were more critical of the policies, and they were exposing policy failures, and their use of science information was, of a better quality. When it comes to individuals, and this is, I think, my last bullet, and this is what I mentioned in my earlier part of the discussion as well, that over time, over 2 years, what we have seen, and this has been reported now, that people who indulge into misinformation, into conspiracy theories, are the kind of personalities who would also violate the SOPs more than those who do not indulge into conspiracies. And not only they, violate the SOPs, of course, they put themselves into, a higher risk, so they get more infection. But when they have symptoms, they even avoid testing, and they are less likely to go for a vaccine. So if that is true, then that tells us that there are certain people who would think in a certain way and behave in a certain way compared to the other people. And as a communicator, our job is that we bring those who are on the wrong side of direction, bring them, talk to them, communicate with them, and bring them to the right side. I think that's about it. Thank you very much. I look forward to the fellow panelists' discussion and more questions. Thank you. Back to you.
Thank you, Dr. Zaeem. Brilliant. And if I have powers, I would say this conversation should never end, but I have to look at the time. But before requesting Dr. Fareeha, I would like to say a couple of sentences in Urdu because we're talking about communication. तो जो आपने बात की conspiracy theory की or myths की, so I remember that when I got vaccinated and I put it on my Facebook, the first reaction was from a health service provider, and it's very interesting what was written there. Madam, ab to aap 2 saal ke baad mar jayenge. So besides pandemic, we are also dealing with infodemic and truth, which you rightly said, Zaeem Ul Haq Saab, that it is among one of the 7 key actions inspired from Sandman. But truth is very often the first casualty in all forms of wars. So Dr. Fareeha, please enlighten us that how to manage infodemic and what health service providers should know about this, and why is there so much hesitancy that I have seen on mass media, the Executive Club of Masses, the television, where people are coming with the stories and they're saying that if you get vaccinated, you will get this and that, and even 70 years old men, they are saying, hey, you will become infertile. So, there are a lot of propaganda, myths, false assumptions, and so many things. I mean, we are good at creating memes and jokes about it, but this is really a serious issue. So over to you, Dr. Fareeha. In 10 minutes, you are going to tell us about management of infodemic and why we are hesitant, as Pakistanis, we are hesitant to get vaccinated.
Thank you, Dr. Rakhshanda. That was a very enlightening talk by Dr. Zaeem. I'll try to be quicker, I guess. because we don't have a lot of time. I'm unable to share my screen. I didn't have a lot. My presentation was actually just an outline, so I'll just talk about things in general. Um, what we understand by health misinformation, disinformation, communication, and miscommunication. Think of it in the context of if you want to buy a car or even you want to buy a cell phone, you want the best information in the market. You go to multiple sources, you go ask questions, you seek information, and then you make up your mind. And that's because you're probably trying to weigh in the cost that you are going to incur on yourself with the benefits that you're going to get. So information is basically a necessity when you are trying to make a decision. It goes for purchases, it goes for the schools, it goes for universities, it goes for every decision that we want to make. We need information for that. What happens in health information and communication? Dr. Zain touched upon a lot of the really critical aspects. I'll be more, I guess I'll be less of a technical scientific person in here because that has been my issue all along. When scientists talk, nobody understands what they're saying most of the time. And that is the problem a lot of the times. We say things in language that is not easily understandable by masses, by a layperson, by someone even with a PhD, not necessarily in health sciences, or may have a difficulty understanding what we are trying to say. Messenger RNA and messenger and DNA and nucleus and mitochondria, and these are just the names. And that creates this gap in communication. So what happens is there's this gap widens as we evolve and as we try to understand things. You can't just run to dictionary.com or Merriam-Webster for every word that you hear, and that kind of is a huge problem. But that is not what we think of when we're talking about misinformation and disinformation. Misinformation in general is not malicious. It's like your dad getting this text from one of his friends that lemon juice cures, I don't know, psoriasis. Or if you drink turmeric with milk every day, you'll not get cancer. Stuff like that. So that's well intentioned, but not based in science necessarily. There are no studies to prove or disprove any of that. But at the same time, as we've seen as COVID has evolved, especially in the last 2 years, that a lot of the communication that we see coming out from non-reputable sources is a mix of misinformation and disinformation. Disinformation is when you're trying to give bad information with malicious intent. Like, you don't want people to get vaccinated. Why? Why don't you want to get people vaccinated? So someone like my dad would say, oh, they are giving no, well, not my dad, some dads, some moms, 5G chips. I'm like, we don't have 5G towers. What are you talking about? But then there's the other people would be like, it's personal freedom. It's my right not to get vaccinated. It's my right to tell people not to get vaccinated. And when you ask them what's the scientific evidence, oh, you get autism. Well, adults don't get autism, but that's the myth. That's the disinformation, and that spreads like wildfire. And there is no way to control it. Once it's out, it's out. People are believing that. I've had discussions with academics teaching at the best universities in Pakistan who are so strongly against COVID vaccine. They believe that natural immunity is better. Now, why do they believe that? Because someone told them that. And that is where this talk comes into play. I am trying to be brief. So what happens is when we're trying to fight these misconceptions, misinformation, the main reason is that usually at the beginning, for example, at the beginning of COVID, I remember a very reputable infectious disease specialist from a very reputable hospital in a very reputable um city of Pakistan came and said, don't wear masks. And I had this conversation with people that, oh, why don't you want to wear a mask? Because ABC from XYZ hospital said so. Like, it's common sense. When you have flu, you have to wear masks. Oh, but the virus can go through the mask holes. Uh, and other pseudoscience logic was thrown at me. But the ultimate cause was that one of the very visible, reputable people in the country said, don't wear masks. And he got his guidance from WHO and CDC, who were wrong. But we got into this whole mask, no mask, and it still continues. 2 years and about a month since the pandemic was declared, and we're still combating this on this front. The masks are good or not. What evidence do you have? And this is something that we will keep confronting regarding COVID. And the reason is that on day 1 or day 2 or day 20 or day 30, we did not try to formulate a proper strategic approach to health communication to dispel health disinformation and health misinformation. We did not create sources. I mean, yes, NCOC has been very good at messaging, but let's be honest here. Those NCOC meetings that we saw on TV, nobody was wearing masks. Why am I, Joe citizen, expected to wear a mask when that minister or that person or that general or that bureaucrat is not wearing a mask? Is the virus scared of them? What's going on here? Are they lying to us? Are they trying to make us do something that they're not willing to do themselves? How can someone tell me to do something that's good for everyone and not do it themselves? And this created this whole trust issue. So everything that came after was couched in that hypocritical or, not very smart approach, because we look at people, like Dr. Zaeem also said, we follow people around us. So if we see on TV no one is wearing a mask, Prime Minister is not wearing a mask, cabinet meeting is taking place in person, why can't I send my kid to school? Why can't I go to a wedding? Why can't I go out and have lunch with my friends or breakfast? I mean, why not? And this kind of mistrust resulted in erosion of the actual message that we are trying to protect ourselves and those around us. So here we are looking at a barrage of mixed messaging, which contributed to this, how to put it, the whole thing, if you look at it from a very distant perspective, like the whole thing is a very, very bad example of health communication, because it let a lot of things happen just because we did not have a strategy and we did not have the right training to communicate. Like I am a doctor, I'm a medical doctor, but I'm also a public health specialist. So I have a bit of a one foot in one world and the other in that. So I'm a half scientist and I'm a half social scientist kind of a person. Even then I have trouble explaining some complex ideas to my mom or my dad or my family who are not doctors. And I cannot imagine that someone who only studied up till 8th grade or 10th grade could understand what I'm saying just because I'm saying it very emphatically or I'm saying it with so much sincerity. The words don't make sense to people. And now we study in English. That's our medium of education at this level. Then we have to translate it into Urdu, and then we have to translate into local languages, regional languages. So we have to translate into Pashto, we have to translate into Sindhi, we have to translate into Saraiki, Punjabi, Brahvi, Balochi. What happens then? The message gets lost. It's not just how we are, the message is not crafted well, it's not communicated well. And then we have this mistrust because of our own actions. The public does not trust public health people. Public does not trust leaders. Public does not trust these voices who are supposed to do good for them. And that has resulted in a lot of infodemic. So that's where the infodemic, at least in Pakistan, has come into play. That we we have a very paternalistic attitude, unfortunately, toward our lay public. We are like, I said it, so do it. I am an MD, I am an MPH, I know best, so do it. I'm telling you to do it, so do it. Well, I'm not going to do it. Go away. I'm not doing it. And that kind of, well, you can make people or like force people to wear masks, but what do? They lower their masks to their chin, so their chin is basically masked. When they see a cop, the mask goes up. What good does it do? It doesn't do any good. Um, Regarding vaccine, and this has also created this huge vaccine hesitancy problem that we are seeing. Dr. Zaeem, you're working with Gavi. I'm working with Mott McDonald right now. We are monitoring all the Gavi operations regarding COVAX right now, and we did the MR campaign as well. So MR campaign was funny because parents would say, no, we're not going to get our kids vaccinated. Why? Because you're giving us COVID vaccine. We're like, no, we're not giving you COVID vaccine. We are giving you measles rubella vaccine. No, you're lying to us. It's really simple. They don't trust you. So, yeah, we know that, we know a lot, but we can't say a lot of things. But these kinds of things worsen vaccine hesitancy. People don't trust us. And that is the reason we need to build that trust. And that comes not from having Twitter wars or, Facebook wars, because people who are sitting there literally have a lot of time, which you don't. We need to revise the communication strategy, which is the mitigation part and all this. And that is we go to the public. Once people have made their mind, they're not going to change because someone at Twitter is telling them, to listen to you. They're not going to listen to you. They don't listen to Bill Gates. They call him whatever they call him. I mean, he's been predicting this for years, and people blame him that he knew because he was going to do it. Imagine that. This is how we get into this whole debate, which takes us away from the true message, and that is public needs to be made aware of and a stakeholder in their own health. And that is only going to happen when we talk to them. When we don't talk down at them, but we talk to them. We hear them, we listen to them, we answer their questions in a way that they understand. What happens at our end, like I said, physicians, public health specialists, the educated elite, we do not know how to talk to someone who is not at our level. So we talk down at them, and that creates this gap, worsens the gap. And one of the reasons I realized, because med school is basically, they shun you from using basic normal every day-to-day language. It has to be medical speak, so you forget how to talk like a normal person anymore. And we need to train our physicians and healthcare workers to talk to people in a way that they understand, so we can get the message across. And that's the only way to fight this infodemic, make people stakeholders in their own health. So this is where I will stop, because I think we are running out of time. I hope that I did not overshoot the 10-minute mark. And if there are any questions, just shoot them my way and I'll answer them if we have time later on. Thank you, Dr. Rakhshanda.
Thank you, Dr. Fareeha Irfan. You nailed it. And what a candid presentation. I mean, we all need to develop the courage to listen to the truthful, content as well, besides, suggesting that we have to be truthful. So coming to you, Dr. Syed Ali Hussain, you are interested and your work is about mental health, digital audience, behaviors, social engagement, social media. And so, I mean, you work with communities, with people, and you understand. I don't say that you read their minds, but you know them. So tell us that after listening to Dr. Zaeem Ul Haq, Dr. Fareeha Irfan, and being an expert yourself, why do you think that we need to invest in research in this particular area? And so I'm just looking at the time. So I'm clubbing actually 2 or 3 questions, and you are an expert and you will handle it. So, and I'm sure that you must be doing research right now as well, and you're writing number of papers. So what kind of research you do? Is your research different from others? And if it is different, why is it different? And being, as I said, that the person who looks into people's behavior and social norms as well. So what are the implications of these visual communication, and with a special focus on mental health? And before I just finish my question, it's a long question. I have been going through some of your works and taking inspiration from Dr. Zaeem, that the key actions of Pakistan, and for any other country who is interested in dealing with any crisis situation, not only this pandemic, is to be truthful. Now, this is very, complicated thing for me, because constructing truth, because we want to be driven by data, but whose data? Is it unbiased? Is it correct? Is it politically correct? And is data is also influenced by desires, and how to construct truth, and how to recover truth, and how to sustain truth. So I have make it more very complex, but you can demystify it. Please, Dr. Ali, tell us.
Thank you very much, Dr. Rakhshanda. I really appreciate your question. I think it's a very important question. I'm going to share my screen and start, and will also answer this question during my presentation. So, just 1 second, please. Can you see my screen? Mental health communication.
Yes. No, it's gone.
You
were seeing it. So.
Can you see now? Okay. So I will be talking about 2 studies that we have done on this topic. And when I was working in Pakistan, my focus was on mother and child health communication. But when I went to United States and Michigan State University for my master's, then I noticed different health issues. And there I did not, so I had to find something to work on, and I found out that depression on campus is a big issue. And actually the reality is that it is a big issue now, not only in the West, but also in here in Pakistan. And it has been an issue which is generally less talked about. And it is also an issue on which a communication intervention can do a lot of help, a lot of benefit. So as you can see from the numbers here, this is from 2017, is that 40% of students on campus felt overwhelming anxiety at some point in the last 1 year, which is, if you quantify it out of 25,000, it's around 11,000 students. And then 15% report that depression has affected academic performance. So these are only this is just the tip of the iceberg of the problem right there. And then there is a lot of discussion about social media and how it causes or it induces anxiety and stress and depression. So generally people think that a lot of social media causes it, but the reality is not that case. And again, through research, we find out that some social media are actually good for mental health. For example, YouTube, Twitter are generally good for people because it is more informative and more awareness oriented, more educational. Whereas Instagram and Snapchat are the ones which have been found most harmful. And so looking further into it, if you look into why Instagram, is because it has a lot of visuals. So this was my first research question, that if visuals has to do something with mental health, what is it that is going on there on these social media sites, and how we can use the visuals again to do something about it. So this was the first article that I wrote, is this what depression looks like? Visual narrative, yani kahaniyan of depression on social media, which is generally visual social media sites like Pinterest, Instagram, Tumblr, etc. And what I was interested in doing is based on a photo elicitation methodology. So for listeners, it is important to understand that once we identified our research questions and then we identify our research method, which is photo elicitation, there is always guideline and help available in how to walk on that roadmap to answer that research question truthfully. So I was downloading now these images I did not create. This is from the community of people who are living with depression. And so they are posting these images on these social media sites to express themselves or to be part of the community. And so looking into this image, if an individual like me who is not living through depression may make his own assumptions or try to understand it, but the scientific method is to go and ask the audience through interviews and focus groups, which is called a photo elicitation interview, in which you ask them questions about what do you see in this image and give me an example to understand it. So that's what I did with 70 images, and my research was ethically approved, and I was working with psychiatrists. So all of this is matters in health communication. As a communication person, I was not working on my own, but I had scientific help from people who are experts in this, and we are working together. And so they helped me finalize these images, and then I was using it interviews, and then a lot of narratives come up. So if you look into the image on your left, which is the blue one, this is what people say depression looks like, sadness. But in reality, depression is much more than that. It looks like sadness, yes, a little bit, but then there is other thing, anxiety, guilt, hopelessness, isolation, self-loathing, and also nothing. So once you talk to someone about mental health directly, even if you know them, it is very hard for them to open up and talk about it, even in a very confidential setting. But through images, it made it easier to talk about it. Because every time I was asking them a question, I never said, please you tell me, how was your day? I never said that. I always asked, please tell me what you see in this image. And what causes their attention is their focus on their own way they were looking at their own illnesses and conditions. And it also helps them talk about it in a safe space. And because I was asking them to give me examples, so they were also sharing with me a lot of ways it actually manifests in their lives, how it causes, what do they do about it, and how do they deal with it. And so is the next image and the next image. Now here it's important to understand that among all the participants, depression was being expressed differently. What one person's depression is different from another person's depression, although they both talk about the same image, but it's not the same. So there's a lot of diversity in there. And more images into it, and going through the images, I was able to extract a lot of narratives, a lot of real life experiences of what this is about. So I was amazed to see how much detail they could go into. If you look into the image on your left, the person sitting inside his own head. So they were immediately able to understand it, and they were immediately able to articulate it. And it was not for them कि ये पता नहीं क्या है. They were immediately saying, oh, this is what is happening here, is that you are trapped inside your head, and there is light. Sometimes the light comes in, sometimes it does not. And all the rats that you see on the floor are my thoughts, which are whispering into my ears. So they have a lot of details to what's going on. And the image on your right is, are you okay? Yes. Are you lying? Yes. It's another very important part of depression, which is not able to express and articulate that, yes, I'm going through a tough time and I need help. So the point I was trying to make here is that in health communication research, what we do is based on scientific models, theories, and then and there is a lot of literature available out there to help us guide through those models and find the variables that we want to test, and then find the relationship between those variables. So these are the images in which I was actually talking with those one-on-one in front of me, photo elicitation methodology. And another part of health communication research, collecting data, is that it should be replicable. The way I have done it, anyone in the world should be able to replicate it in the country that they live in with the audiences through my research article. That is very important for me, to write a paper in a way that it is replicable for other illnesses also, for different audiences also, and for other countries, geographic regions, etc. And another very important part of health communication research is to find tools to collect data, and tools to analyze data, tools to visualize and present data. So what you see here is a linguistic and sentiment analysis of how people actually felt when they were talking about those images, using it as a way to express their depression. In a nutshell, I would not notice, but because I transcribed the whole interview, which is more than 1 hour long, and then using a software which is called LUIC, Linguistic Inquiry Word Count, I was able to see the sentimental composition of the whole interview. One interview. This is one. And without these tools, we would be sort of in dark. Like I could say, yes, they talked a lot about sadness. That is true. They use a lot of sadness related words, which is on the right. But then all the other words that they use mostly are positive words. That's a very important finding for me. And that's a very interesting finding for psychiatrists and therapists and counselors to use images in therapy sessions, because even though they are talking about an issue which has to do with sadness, they are actually feeling good during the process. This gives a lot of hope to use it in therapies. And again, whatever we do, we give the evidence. As you can see at the bottom, there is this article from where I got the dictionary that was being used to make this chart of the emotions, the 16 big emotions. So here, the main point I'm trying to say here in health communication is the use of tools to ease your work. And now I move to the next research, which is the last one I'm going to talk about today, is about once I find out what's really going on there, then how can we help? And the help is professional psychological help and also social support from friends and family. So this is the second article that we wrote for American College Health, and it focused on nostalgia, and it also focused on leaving the box, like going outside the box to find innovative solutions. So a lot of advertising communication use emotional appeals based on joy, surprise, thrill and excitement, or negative emotional appeals such as guilt, shame, and fear. But in the advertising industry, I noticed that there is another emotional appeal which is called nostalgia, nostalgic emotional appeals, and we all have been buying products based on this nostalgic emotional appeal. So it is a bittersweet emotion. It's both sadness and joy at the same time. It's like a one thing, sadness and joy, with sweetness more than the bitterness, with a like overarching sweetness about a sentimental yearning for the happiness of a good old days, former time and place in your childhood. And I wanted to ask, like the second research question was, can we use nostalgic emotional appeal to influence people who are living with depression to go and seek help from a psychiatrist or a counselor? Just like the advertising agencies use nostalgic emotional appeal to influence them to buy a product or service. That was a difficult question to ask because depression has everything to do what happened in the past. And evoking the past is a dangerous move, especially for people who are living with depression. So again, there are a lot of examples out there. And this was the first time we tested it for depression. And so for this research, we followed an experimental design in which we made two different messages. One is nostalgic, experimental, and a control message. So if you notice here, this is the show reel of the nostalgic message. It starts with childhood memories and then talks about childhood memories. Then it talks about the depression starts. It sets in from the high school. And then the movie moves into seeking help from a counselor, writing a diary, and then moving on, like living with depression and actually seeking help. And then there's a control message, which does not show the nostalgic part of it. So the nostalgia is missing here. It starts with depression and then it continues with the sort of the same pathway. This was important because again, research informs research. During the first research article I showed you about interviews, when I asked the question, how did depression started? And surprisingly, a lot of them actually went back to their high school days. Something happened during this time that caused me depression. So it could be divorce in family, could be moving away from houses, could be some other traumatic incident, also very, very different things, but not in their childhood, but in their high school days. And so I learned from this experience that if I have to show them nostalgia, it should not start with their high school days. It should start with their childhood days, the good old days when they were 7 years old, 6 years old, when things were really good and better. Because I don't want to have to, relapse something. But then it moves into high school depression, which is actually realistic. So it's a smooth transition into it, and then help seeking. So here are the results. Now, before going into results, I want to say that these results or the whole research was guided by theories which have been evidence-based by many scientists over the last 40 years. So I was sort of walking on the same footsteps, and that's okay because you learn from others. And then the theory of planned behavior was used into it. And my the main goal was to, again, intention to seek counseling. That was my goal. That's what I want to promote. And through this experiment that I did, I find out that participants who watched a nostalgic video, they felt more emotions, which were joy and happiness and a lot of positive emotions, which in turn predicted that they have a favorable attitude about the counseling center. That in turn predicted their intention to seek help, and no other route predicts it. So this helps us to some extent. It's not okay to say cause and effect, but it sort of gives a direction that these are the main predictors and influencers. So we need to focus more on. So other people who do the same research, if they find the same pathway, then it sort of helps us replicate it and introduce it into practice. Now, attitude towards the counseling center was important because people had unfavorable attitude about the counseling center. A lot of people who live with depression, they say they don't like their counselor. It has long waiting lines. It's very expensive. It's not accessible. I don't want to go there because people will say I'm mad. So there's a lot of attitude thing going on in here. So we address this thing not directly, but through the emotions. The bitter sweetness of nostalgia was very powerful. That actually led to improving their attitude towards the counseling center and the intention. So this was the bigger model that I used in here. So the help is out there in terms of model and theories. I'm not going into it because that's what I was mentioning, the theory of planned behavior. So overall, I talked about two studies here, which one, and both the research one informed research two, and this is a continuous journey. We have done other researches also on this. We have also used virtual reality. I'm currently teaching at Habib University. I'm living in Karachi. And while I'm here now, because I have more exposure, so now I can find the ways I can culturally adapt these technologies and these messages to our audiences, which in Karachi is a very diverse. And I'm more than happy to answer any question if there are. Thank you.
Thank you, Dr. Ali. And I noticed some exchange of information and questions among the panelists. And on Facebook live streaming, there was an audience. There are still some people who are watching, and they are actually admiring it. And this is also a good indicator that they are listening to the experts. And there will be more questions. I'm sure when this discussion would be uploaded by PUAN on the YouTube channel as well. So I have to conclude, though I do not want to conclude, because this powerful discussion has raised many questions, and it has responded to many questions as well, but it has raised many questions, and research informs research, as you said. So there needs to be more research, and research needs money. So my parting question from all of you is that if you are given, and I'm sure somebody will approach you, the required resources, then where would you like to put that money? Because we have, usually $1 in the kitty, multiplied by some more zeros, but there is always dearth of resources and time, because we are into 2022 and 2030. The agenda 2030 is very close, leaving no one behind, and there are so many. So how to prioritize? So where would you use that money, and in which dimensions would you be focusing on? So I will start from Dr. Fareeha, if she is still here. Okay.
Yes, I am. I can't hear you. Your mic is muted.
Yeah, I asked that if you are given the required resources, then where would you like to invest it in the broader picture of health communication? I mean, that's very broad, but in which
Yeah,
particular area? Yeah.
that's so broad. Oh, I would start with training of scientists and health professionals first, because they mess it up the first, and then if we look at it from public's perspective, um, whenever you talk down at someone, they're not going to listen very well. I mean, try talking down to a 3-year-old and they're gonna do what they're gonna do. Expecting adults to behave rationally in the face of orders and such, well, that's not gonna go well. So community outreach and making people more engaged in their own health decisions is where I would invest in CSOs, community outreach. I've seen it, it works. People will have more trust in their polio vaccinator who visits their house every campaign than they would trust the higher ups in EPI. So that's where human resource and training would be my first step if I get the money.
Hey, good luck. And Dr. Zaeem.
Yeah, so I'm not sure about the amount of money that you're going to give, but
A lot of
I'm
money.
assuming
A lot of money.
I'm assuming a lot of money. Yeah. So, and I would actually link the recommendation, if you may call it, to what Dr. Ali and Dr. Fareeha have shared. And both of them have actually highlighted very important areas. Listening to Dr. Ali, I was thinking that it might be different, a little different in our society, because what the data tells that the kind of mental health issues, including the metabolic issues, they perhaps have initiation even earlier in our communities. So if Dr. Ali has money and he listens to my suggestion, I would say that maybe start early than the high school. And listening to Dr. Fareeha, I was thinking, yes, trust is the most important, component in the whole discussion of COVID, and actions of people who matter. Those actions actually build trust. It's not that you can create through communication. It's not a turnkey operation. You cannot do it in one day. It has to, it has to be there. And one of the ways to ensure trust in a pandemic is actually for a political leader to think about the whole community, the whole country. And that whole people includes those voters and those people as well who belong to the opponent party. So reaching out to the opposition in any country, have we seen that? And if we have money, how can we ensure that we convince our leaders that in a pandemic situation, you are the leader of the entire country? You may be coming from a country where you belong to more than your own country. So transcend those differences for the sake of people. How can we do that? But I know these are two, especially the second one is a big ambition. Very focused. I would also, think about examining what I was saying earlier. How much has the mass media played a role, positive role as well as the negative one in our society? We can examine that if we have resources. Building capacity, no doubt, especially, crisis communication, when you can avert a crisis, and if a crisis has happened, how you can, talk about it. So that capacity needs to be given to people at the interface at all levels, the frontline health workers, the midline, the managers, and the highest policymakers. And lastly, I think social media has a presence in our country, but it has a unique presence. It is within a certain, layer of the society, which is kind of, subordinate layer at the upper level. But they can help in diffusing the information downwards, the trickle down. So we need to find ways in which we engage people who are on social media and inculcate some thinking and some action that they, can transfer to their mali, to their gardener, to their housemaid, and people living in the rural areas. How can we do that? I think if we want to prepare for the next pandemic, these are the three things that we critically need. Thank you.
Thank you. I can see Dr. Fareeha has raised her hand. So yes, ma'am.
Just a quick comment building on what Dr. Zaeem said regarding crisis communication. We need to have a playbook. We can't just, chase our own tail every time some disaster happens, especially regarding communication and bringing people, making people become a part of the solution. What we do is, oh my God, this happened. Oh my God, now we are scrambling for resources and we are scrambling for experts and we are scrambling for everything. And this is something that we saw very vividly in this recent Murray disaster. If only we had given a handout to the people driving onto the highway saying, just keep your tailpipe exposed, don't let it be covered by snow. If you get stuck, do this. If you just give them an idea that this is what they might face and this is what they can do to protect themselves. That's not hard, but that requires forward thinking and not, just, oh my God, this happened, now what we are going to do. And well, communication, especially at vertical level, I find it very annoying that people communicate through WhatsApp. So if my phone gets lost or my account gets hacked, the whole communication and planning and troubleshooting is gone. There should be a definitive way of handling these things. Have a playbook like Obama made for the pandemic, I believe. Not so many of us are willing to just work on these things. It would be a crime not to use this local expertise. That's it for my end. Thank you so much for having me.
Yes.
Yeah.
Sounds
So,
cliched, but as they say, last but not least, Dr. Syed Ali Hussain Saab.
yeah,
Lot of money. So what will you do?
work together. Basically, like Dr. Fareeha and Dr. Zaeem was mentioning, that Dr. Fareeha mentioned we need a playbook. Dr. Zaeem mentioned we need to have a social media campaign. Now that playbook is the content and social media campaign needs cost. So making the content takes money. Disseminating the content to the audiences requires money. So developing a whole holistic campaign and reaching out to audiences and measuring its impact and then changing the messages based on the responses. This is where I will do, but in a team, like with all of experts from different areas.
Okay, great. Yes, no doubt working together works. And if I may add that if there is a lot of money and all experts are given this power that they can invest in some specific areas of health, especially health communication, then I would suggest whenever Dr. Fareeha, Dr. Syed, you get that money, that please invest some of the resources on defining inclusivity and teaching empathy, because we see these words in all the documents by powerful platforms, but in reality, there is a gap, just as there is gap. So thank you very much. And this discussion is ending now, but the conversation is on. Stay safe, stay healthy. Thank you, PUAN, for organizing this very relevant, very informative session. Thank you.
Thank you very much for hosting, Dr. Rakhshanda. And thank you, PUAN.